Hello, everybody. Welcome to today's session. I hope you all can hear me. And I hope you all are safe after our little storm last night that came through Houston. Today, we're going to talk about an important topic, especially for those who are doing nuclear cardiology with regard to how to image patients with specifically SPECT and also PET imaging, and what are the fundamentals that allow us to do it properly. So let's first start off with what exactly we image. First of all, what we don't image are alpha particles, which can be stopped basically by a sheet of paper, beta particles, which are electrons, which are also can be stopped by tissue paper. And so what we do image are gamma rays, because gamma rays can penetrate tissue, whereas these particular particles, if you were to ingest them, they would never get outside the body to a camera to be able to see them. So there are different types of radiotracers that we use in these different types of modalities. With single photon tomography, our radiotracers range in energies from 72 keV, which is thallium, up to 140 keV, which is technetium. With positron emission tomography, we always get 511 keV, independent of the radiotracer that's being used. And compare that to what we use in CT angiography, which is anywhere from 70 to 140 keV. You can see that with PET imaging, you actually get much higher keV or penetration, photons with penetration than you do even with CT. And the CT is actually very comparable to what you get in terms of penetration as compared to single photon tomography traces such as thallium and technetium. The other important thing to recognize about radiotracers are their biologic effects. And of course, there are several different ways of looking at this: equivalent radiation dose, which is based on the radiation emitter. And we know that alpha particles, as we talked about, can be stopped by a sheet of paper, but they also have a tremendous adverse effect. And they, in fact, cause about 20 additional ionizations for every emission that is generated. Whereas beta and gamma have a factor of only one ionization per emission. So alpha particles, even though they don't penetrate very well, are extremely dangerous. And the other thing is the effective radiation dose, which is based on the tissue sensitivity. So breast tissue, lung tissue, all of these tissues are more sensitive than, let's say, brain tissue to any degree of radiation. So we have different setups in terms of what tissue sensitivity is for each particular organ. As I was saying about alpha particles, they are actually pretty dangerous. And you probably will remember many years ago about the issue of polonium-210, it being the assassin's choice. Because once you ingest it, even though it doesn't get outside the body and you can't detect it with a Geiger counter or anything else because it's stopped by tissue before it gets out into the body, it's extremely deadly. And in fact, there was a spy, Alexander Litvinenko, several years ago, who actually died from polonium poisoning, which was an alpha emitter, and kind of brought this whole to light. Okay, so let's get into some of the other issues. First, let's talk about beta decay or nuclear decay in terms of what happens with radiotracers. And you can decay by many different ways. You can have decay by beta emission. This is the more typical of what you see when we take a tracer like molybdenum, which then decays to technetium. And that's what we use actually as our radiotracer. There's also isomeric transition or internal conversion. That's technetium 99M, technetium 99. There's electron capture. That's particularly in proton-rich nucleuses where we go from thallium, where it degrades to mercury. And then we have many different positron emitters, such as strontium, which actually degrades into rubidium, which is our positron emitter through electron capture, where actually the nucleus captures an electron, changes the proton to a neutron, and you actually change the element from strontium to rubidium. So there are many ways in which these occur, both in terms of developing the radiotracer we're going to give the patient, such as molybdenum to technetium, as well as looking at what happens with the radiotracer that's injected, such as thallium, which degrades to mercury. Also, there are many ways in which particles interact with matter, and this is now we're going to talk about alpha and beta particles specifically. Usually alpha and beta particles lose energy through collisions. There can be excitation, where a particle goes near an electron and excites it to a higher level. There can actually be where a particle comes in and kicks an electron out of its orbit and causes what we call a characteristic X-ray, which is here. And there's also this very interesting phenomenon called Bremsstrahlung, which is a German term. I can never really pronounce it very well, but it's breaking energy, breaking radiation, where a particle goes near the nucleus of a substance, and as it gets near the nucleus, it slows down, and with slowing of momentum, it gives off energy. And in fact, in CT imaging, ionization, which is this particular way of, someone's got a radio or something on. I'm having difficulty. If you could turn off if you could mute your device or whatever. In CT, we actually utilize ionization and Bremsstrahlung to create X-rays that will allow us to image. Okay, in nuclear imaging, such as SPECT imaging, we actually use ionization as well, but it's not through using particles, it's through photons that are emitted. And then these photons emitted by technetium or thallium actually kick out an electron, an inner orbital electron, and that then allows an outer orbital electron to fill that space. And as you go from a high energy outer orbital to a lower energy inner orbital, you give off energy, and that's what we call light or scintillation. And that's what we see when we have scintillation within a crystal. But remember that photoelectric effect or interactions with matter also occur in tissue. And we see that, for instance, with Compton scattering, both in crystals and in tissue. And in this situation, instead of getting a full transfer of energy from the X-ray to the particle, you have a deflection of the photon, and you only lose some of the energy instead of losing all of it to the electron. So we'll talk more about this, but Compton scattering is a major problem in nuclear cardiology in terms of reducing spatial resolution. Okay, and then in the other area that we're going to talk about is how you talk about positrons. So in PET imaging, we use positrons instead of X-rays or photons, such as what we see with thallium, and these positrons are actually developed or occur due to beta decay within the nucleus of all PET radiotracers. And what happens is that the proton in the nucleus of the PET tracer is converted into a neutron, and thereby emits a positron and a neutrino having no mass and no charge. And so what you see here is what you might have. Here's a PET agent that's been administered. The transfer has a curve where you form a positron. The electron that's emitted, along with the neutrino that's emitted with the positron, is neutralized almost immediately when it leaves the vicinity of the nucleus. But the positron goes out a certain distance, and then it interacts with an electron, a negatively charged particle, and you get matter-antimatter interaction, and you get annihilation. You've probably all seen that on Star Trek, right? Where you get annihilation. It's a very, very common thing. So, and that annihilation leads to 511 keV photons that go in opposite directions at 180 degrees. Now, what's interesting about some of these radiotracers is that, let's say, fluorine or F18 actually has the best spatial resolution of the PET tracers because it has the least amount of energy. In other words, the positron is emitted, and because it's got lower energy, it annihilates much closer to the area of emission than, for instance, N13 ammonia positrons or rubidium positrons, which have much higher energy. So F18 actually, if you could get a radiotracer with F18, which is actually being worked on now clinically, that would be much better because the spatial resolution of F18 is better than what you see with rubidium. And so with PET, the higher the energy positron, the higher the energy of the positron, such as rubidium, the lower the spatial resolution because the annihilation occurs further from the site of origin. Okay. So we talked a little bit about Compton scattering, and Compton scattering is important because instead of a gamma ray or a photon coming in and being annihilated and losing everything, you have it simply scattered, and you have an electron coming off, and there's a scatter angle to the photon then where it comes in here and then it scatters. And depending on the angulation of the scatter will determine how much energy is lost in that photon. And so we see that the greater the angle of deflection, the greater the energy that's lost. And we also know that the higher the energy of the radiotracer, such as technetium, which is 140 keV versus thallium, which is 72, the greater the energy loss per degree of angulation. And so if we look at, someone's got their phone on again.
You did a cardiopulmonary exercise.
So if you look at the scatter angle in terms of detecting photons on a gamma camera within a certain energy window, and we usually use a 20% window, you can see you can have a deflection of 78 degrees from the initial path with thallium and still be detected. With technetium, it goes down to 54 degrees, which is actually much better because that means, you know, you're looking at photons or you're collecting photons that are pretty much in the same path as the original photon was. And with F18, for instance, a positron emitter, it's 27 degrees because of its much higher energy. So this idea of Compton scattering is very important because we want to avoid Compton scattering, and Compton scattered photons we really don't want to detect because they originated in one place and they'll be counted in another place and you'll lose spatial resolution. And not only can you get a Compton scattered electron or a photon, but this can occur in many different ways in tissue. In other words, you can have a photon emitted by the radiotracer, and then it hits tissue and it's deflected, and then it hits tissue again and has another deflection before it ever gets finally ionized and hits the crystal if it were to do that. And so you can see that if it started here and ended here, you're really going to destroy your spatial resolution or impair your spatial resolution. So that's another reason why, you know, because of this different Compton effects that we see, that we like to only image photons of certain energy within a certain energy window. Okay. Now, what is the likelihood of seeing either a photoelectric effect where you basically get annihilation of the photon and it's converted to energy, or a Compton effect where you actually get scattering? And it turns out that in lead, and it doesn't matter whether you do this with PET agents or with technetium 99M, which is 140 keV, or thallium, in lead, you almost always see photoelectric effects, complete absorption of the photon. In the sodium iodide crystal, with both technetium and thallium, most of the time you'll get photoelectric effect rather than getting Compton scattering. But look what happens in tissue before it ever gets to the camera surface. Most of the time, what you see with both thallium and with technetium is actually scattering, within tissue. So this is a major problem. That's why when these scattered photons are being looked at, we look at the energy of the scattered photon and only accept those photons with a certain energy, because otherwise you'd be really degrading your spatial resolution even more so than you would ordinarily. And again, remember the thallium and technetium, the primary tissue interaction is Compton scatter. Okay. Now, I just want to show this because there actually are similarities. And one of the reasons, I guess, why I got interested in CT many years ago is because there's a lot of similarities between nuclear imaging and cardiac CT imaging. First of all, as I already showed you, there's a lot of similarity in terms of the type of KV that we use, depending on the radiotracer and the KV that we use in CT in general. And again, the KV is important because it's a way of penetrating tissue and getting photons out either through the body with CT or out of the tissue to the gamma camera in nuclear imaging. And so we have two concepts here. We have KV, which is basically tissue penetration, which is seen in all these radiotracers and in CT. And we have photon flux. And photon flux in CT is based on MA, the amount of electrons that you're actually pushing through at a certain period of time. With SPECT and PET imaging, it really depends on dose. How much of a dose you're giving someone, how many millicuries of a substance you're giving in terms of getting maximum amounts of counts, which is the same as photon flux in CT. And so with nuclear imaging, basically this is an emission scan, right? We're giving a radiotracer, it's being emitted in the body, it's being pushed out, and it's being scanned or being collected by a scintillation gamma camera, okay? With CT, it's a transmission image, okay? And this is based on how well photons actually get through the body or are attenuated in tissue before they get to the detector arrays. So CT is a transmission type of scan. Nuclear imaging is emission with collection of photons, but except for those differences, they're very similar in many ways. So let's get back to how then we construct an image. Now we know something about radiotracers. We know something about energy in terms of the low and high spectrums of energy that these radiotracers have. If we have a source like the liver, for instance, we have an emission of a photon, which may get scattered, it may not get scattered, it may come directly out and then hit the gamma camera or the crystal, which can be in nuclear imaging, most likely sodium iodide, or most commonly sodium iodide. And then you get a scintillation or a photoelectric effect, which is collected and magnified and put on a computer screen so we can see a picture of the liver in this particular case. Okay. There are many ways in which we want to be able to collect the proper photons, okay? And so in nuclear cardiology, we use these things called lead collimators. And lead collimators direct which photons we actually are going to accept and which photons we are not going to accept. So let's take either our heart source or our liver source. And remember that these X-rays or these photons are emitted in all different ways, like all different directions, like you would with sunlight. It's scattered from a point and goes out in all directions. Well, we're interested in collecting those which are parallel to the collimator and are directly coming off the patient. So if you have a collimator, there are certain photons that will be collected that are either parallel to the collimator holes or very closely parallel. And there are those that will not be collected and basically absorbed by the lead. And this way we can focus what type of photons or what kind of photons we actually can hit the crystal and create a picture. And again, this is mostly to improve spatial resolution, okay? We also use this concept of the full width half maximum and the full width 10th maximum to help us determine what our spatial resolution is. And so, for instance, let's say we have a point source here. Every single point source has some Bayesian distribution of where it will be. And the half peak is what we call the half maximum. So let's just see how that might look. Here you have 2 point sources, okay? And here's the half, the half maximum of both of these point sources, okay? And so if you look, actually, you'll notice that when you image this point source, it doesn't look like the point source anymore. It looks like this big glob, okay? And that's because the width, the full width half maximum is so wide that it causes a blurring of the point source. So now you have these 2 point sources and you're trying to discriminate. Well, since the point sources are far enough apart beyond the full width half maximum, you will be able to see both of these points independently. They won't look like the original points in terms of the size. They'll be blurred, but at least you'll be able to discriminate the 2 points, okay? Now let's take this example. We got these 2 points again together. And again, we have the same full width half maximums, all right? And the question is, can we discern or discriminate these 2 points if we were to image them? And you can see that these points lie within the full width half maximum of both of these peaks. And so now you'll see that there's overlap between these 2 points. And so in this example, the points are too close because they're within the full width half maximum, and you will not be able to discern 2 points anymore. You will only be able to discern a big blob that will just look like 1 point, okay? So this concept of full width half maximum is extremely important. And incidentally, full width half maximum not only applies to when we talk about collimators, the crystal itself, which is intrinsic resolution, or collimators where you have collimator resolution, but it's also important to remember this is also applies to what we call energy resolution. These 3 important factors in the creation of an image, okay? So we'll talk about each of the differences in full width half maximums with these particular parameters. So let's first talk about collimator resolution, because remember that on top of the crystal sits a collimator, and that collimator directs which photons can actually be accepted by the crystal for ionization, okay? So collimator resolution is determined by the diameter and length of the collimator holes and by the distance of the point source from the face of the collimator. And since that's the resolution of the collimator, and the collimator sensitivity indicates the fraction of gamma rays or photons that actually get to strike the collimator that will pass through and hit the crystal, okay? So it only makes sense that as resolution improves, sensitivity goes down and vice versa, all right? So let's see what happens. If you look at a collimator, again, this lead plate on top of the sodium iodide crystal, as hole diameter gets bigger, you decrease resolution because more photons can get through those bigger holes that maybe you don't want them to get through, but they get through anyway. And therefore, you increase the number of photons that actually hit the sodium iodide crystal, so you increase your sensitivity. However, if you increase the hole length, then it makes it more difficult for scattered photons to get into to hit the gamma camera or to hit the sodium iodide crystal. So you improve your resolution because now you're getting only those photons that are parallel to the crystal getting through, or the collimator holes getting through to hit the crystal. And you decrease your sensitivity because less of the photons are able to get through. So these are kind of inversely related. Hole diameter, as hole diameter goes up, resolution goes down. As hole diameter gets smaller, resolution increases. And as hole length shortens, resolution goes down. As hole length increases or lengthens, resolution increases. And you have the inverse or the opposite happening with sensitivity. It also turns out that different collimators have different resolution, different sensitivity, because remember, the collimators, depending on whether they're ultra high resolution, or high or low energy or relatively low resolution collimators, the differences between these collimators are the size of the holes and the length of the holes, okay, in the collimator. And so ultra high resolution collimators have very low sensitivity, but they have very good resolution. Again, because very few photons get in, but the ones that do get in are parallel to the point source, okay? Whereas high sensitivity collimators have very wide holes, and they have very short holes, which means that more photons get through. So your resolution goes down, but your sensitivity goes up, okay? This is just a point spread function looking at the differences between different collimators. So here you have a low energy collimator, okay, all-purpose collimator, and you can see here's a point source, and this is what your point spread function looks like. And you'll see that the full width half maximum is this distance here. Now let's see what happens when you bring the source further away from the collimator head. Notice what happens to your point spread function. It gets wider, right? And your full width half maximum gets wider. So your resolution goes down as the source moves away from the collimator and from the crystal, okay? This is using the same crystal, low energy, all purpose, okay? And so you can see what happens here. So the further you get away, you get a reduction in resolution. But let's look at the same point, but now we're going to use a high resolution collimator. Look at the holes are smaller, and the length of the septi are longer, okay? So fewer photons get in, but they're the right type of photons. And now look what happens to your point spread function. Look how much narrower the full width half maximum is here compared to here or here. So it not only depends on the collimator, and you can see the difference in this collimator, all purpose. This is high sensitivity, low resolution, versus high resolution and low sensitivity, where you have much longer septi and smaller holes. So even though the point source may be further away, you still get a better resolution. Obviously, the best of all worlds is to make sure that the point source or the patient gets as close to the camera as possible, okay? So for all types of collimators, resolution degrades as the object is moved away from the collimator face. And that's extremely important when we image patient to make sure that the gamma camera is as close to the patient as possible. And so here you have an example. This is with a collimator. Resolution improves closer when the patient's closer to the collimator as compared to further away, okay? So here you can see the collimator and the sodium iodide crystal, and look what happens to our point spread function here as compared to here. So you want to make sure the patient is closer. The other thing to keep in mind is that not only, as we said, with low resolution collimators, as you get further away, the resolution gets even worse as compared to high resolution collimators. But it's also important when you think about what we're imaging. For instance, the heart, the anterior and lateral wall of the heart will always be resolved better than the inferior and posterior wall of the heart. And why? Because the inferior and posterior walls of the heart are always going to be further from the collimator and from the sodium iodide crystal than the anterior and lateral walls of the heart. So actually, in this type of situation, we use resolution recovery software, so we can actually hopefully improve this inferior posterior wall resolution and make it similar to what we see in the anterior wall. So these are all very important concepts to keep in mind when you're thinking about imaging patients. So let's move on. We've now have our source. We've had a scintillation event. What goes on from here? Well, the scintillating material is sodium iodide, and what happens is every time you have a scintillation or an ionization, you give off a little bit of light, and that light is detected by photomultiplier tubes, and then it's sent to a voltage discriminator, a pulse height analyzer, so we see exactly what the energy of those scintillations are, and if they're acceptable, then we count them and we display the image. Okay. It's important to recognize that there are certain optimal thicknesses of crystals in order to get both the ideal counts in our images. For instance, if you have a very high energy photon, you need a thicker crystal in order to obtain counts, because in a very thin crystal, the photons will simply go through the crystal and won't ionize, okay? This is also shown with something like with technetium, which is 140 kV. There's an optimal thickness of the crystal, after which you don't get much more benefit in terms of ionization. Okay, so that's why, and since crystals are quite expensive to manufacture and all the rest, we try to use the least thick crystal possible to get the maximum amount of ionizations with any particular given radio tracer, okay? And so that's also a very important concept to remember. And it also turns out that this also occurs when we think about energy resolution in terms of maximizing our distinction of what energies are being emitted or being collected from the crystal ionizations. And for instance, with technetium, it turns out that the full width half maximum is actually, for the sodium iodide crystals, is actually optimized with the 140 kV energy of technetium as compared to what you see with thallium. And this is one of the reasons why, when we think about using radio tracers, we don't use a lot of thallium anymore. It's higher radiation, all the rest. But the other thing is that it has much more scatter because it's low energy, and the energy resolution in terms of being able to identify what's a proper photon and what's not is worse with thallium than it is with technetium. And in fact, with technetium, we continue to get better. And thallium has improved over the years too in terms of our detectors, but still nowhere near what we get with technetium. And then once we detect these, the voltage discriminator detects 140 kV photons with a 20% window on a total of 20% window. And so we don't want to collect and detect these photons because they're low energy. So we wanted to detect those photons which are closest to the radio tracer that we actually gave the patient. And for technetium, that would be 140 kV. And therefore, we can actually determine what we call a pulse height analysis, pulse height analysis. And you can see different energies here of different photons that were actually underwent scintillation. But we're only interested in those that are like sort of in the 140 kV range, okay? And so remember that Compton scattering is not our friend. Remember, every time a 140 kV photon is scattered, it loses energy. And it's still, even though, you know, you have to have a fair amount of angulation, like 57 degrees for a Compton scattered photon of technetium to be accepted within the energy window, it still can happen. And so, especially if you have multiple Compton scatters. And so here's your sodium iodide crystal, and here's your optimal photon. Comes right down from the source, hits the crystal, has a full ionization of 140 kV, is detected by the pulse height analyzer as 140 kV, and is accepted. But what do you do with all these Compton scattered photons? Okay, that's where we run into problems, okay? And so This is what happens when you have one Compton scatter, two Compton scatter, three Compton scatters, four Compton scatters. You see you continue to lose energy. But remember that we're only interested in these photons. These photons that have 140 kV or plus or minus 20% to make up our image, because these are the photons which have not been manipulated or degraded by scatter in the patient or as they were coming out of the patient. So these are not going to be, these are not deflected photons. These are the good ones. So those are the ones that the pulsite analyzer will accept. Now, there are different detectors. There's sodium iodide, which we've used for 30 years, and there's also CZT, cadmium zinc telluride, which actually does a better job with our pulse analysis than sodium iodide does. So, we have about a 10% discrimination with sodium iodide, but we can get down to half of that with CZT in terms of identifying photons that are 140 kV that really are 140 kV. Okay, so the pulse height analysis is much better with CZT, and that there are a lot of these new CZT cameras on the market because of their better energy discrimination and because of other issues that make them better cameras in general. In terms of scintillation cameras, we also have to do other kinds of corrections. We have to do photo peak alignment corrections in order to be able to get proper energy peaks. And this is just an example of where you can see better, with energy correction, you see better discrimination of the different photomultiplier tubes in the that accepted photons from the crystal. We also have to look at camera uniformity. Every camera or every crystal is imperfect. And so every day we have to do correction maps on our different cameras to be able to correct for those imperfections. And we do different things. We do integral uniformity and we do differential uniformity. Integral uniformity looks at the greatest variation in uniformity over the entire field of the gamma camera, which is either based on the usual field of view or the central field of view. And it's calculated by the maximum count minus the minimum count in the crystal divided by the maximum plus the minimum. And so you can see here what a typical integral uniformity might look like. The yellow is the usual field of view, the red is the central field of view, and you can see how nice this looks. The uniformity here is pretty good. It's about 5% difference overall. This is a pore flood. This is with a lot of difference in uniformity. You can see the difference between this flood and this flood. This is with a 12% integral uniformity, which is very poor. We try to stay 5% or less. And so by doing these floods, we can then correct for these issues. And so integral uniformity, again, looks at the difference between the highest and lowest peaks. Differential uniformity is another thing we utilize, but that looks at a local neighborhood of pixels in terms of differences in highest and lowest. And we do both of these to get ideas of spatial uniformity in the sodium iodide crystal or the camera that you're using that day. Okay. And there are a lot of reasons why crystals may have non-uniformity. There can be crystal damage, there can be PM tube failure, improper coupling of the PM tube to the crystal, incorrect application of correction maps, etc. But it's important to be able to identify these non-uniformities because they will cause tremendous degradation in your images. Okay, so we have gamma camera uniformity. We also have spatial resolution and linearity, which is very important. And it turns out that with photomultiplier tubes, there's a nonlinear response to light across the face of the tube. And so light going in doesn't always come out the same as light going out. So this has to be corrected for in order to get improvement in the floods. And you can see this is what happens with linearity correction. Here's a flood without correction. Here's a flood with correction. And this, if you were to look at this, this would have less than 5% lack of a difference in uniformity in this particular flood. We also look at our spatial resolution in terms of our ability to discriminate between lines. And so we have these different bar phantoms, which discriminate very small differences and between lines, as you can see here. And therefore, we can image a point source and be able to see what our discrimination is. And on rotating gamma cameras, we also have center of rotation corrections that have to be made. Because remember, we have two heads that are separated, and we have a point source, and there's got to be accurate rotation centers between how those 2 point sources are collected. This is looking at a myocardial perfusion scan with proper point source, 0 pixel deviation. And you can see the defects that occur, for instance, in the septum here with a minus 1.5 pixel, or in the lateral wall with a positive 1.5 pixel deviation in center of rotation, okay? And so if you didn't know there was a center of rotation area, you might call this a septal or apical septal defect or an apical lateral perfusion defect, when in fact the patient had no defect. It was just an artifact. So these kind of corrections are extremely important. And it turns out that there are many different ways we achieve this, as I've already gone through, in terms of how we correct for energy, linearity, and uniformity to get down to somewhere around 2 to 5% uniformity on our floods, so that we have proper imaging. Okay, now let's talk a little bit about constructing an image. We've got all our photons. Now we want to actually make the image. How do we do that? We do filtered back projection. And the way we do that is to get multiple looks at an organ, or in this case, an individual. And where these lines intersect is how we determine how we create our image. So you can see here, for instance, on a heart, this is just one view. This is 2 views. You're starting to see something happening here, a square. This is 3, 4 views. Now you're starting to see the heart, and this is an 8th view. Now imagine if you had 64 views. Okay, you'd be able to create a really nice image where all of these lines intersect. And that's what we call filtered back projection. And filtered back projection is extremely important because it's not only used in nuclear imaging, it's also used in CT. And that's how we actually create an image with CT, with tomographic imaging. Okay, so let's talk a little bit about frequencies, okay? Because frequencies are how we create an image also. So let's look at this particular image. This is the original photo. Now we're going to start to remove the high frequencies and even more of the medium frequencies. And now we've gotten rid of all the frequencies except for the low frequencies, okay? What do you see? Well, you don't see this peak anymore. You see basically just a blur. So it's really important in nuclear cardiology and also in CT to be able to pick what frequencies you want to keep and how much of the high frequencies you really want to take out or keep, okay? It's also about not only, and that's why we have cut points in terms of where we cut out high frequencies and where we keep some and take out others, okay? And that's to help improve our overall spatial resolution. We also have this thing called image resolution. And image resolution is really dependent on pixels, on the size of pixels and the amount of pixels. So here we have a very high pixel image, 1200 by 800 pixels, okay? And you can see that, we have a pretty nice image here. If we go down to here or to here, we see the degradation of the image, okay? Because we've limited the number of pixels and the size, and we've made the pixel sizes much bigger, okay? So we've degraded the image, all right? So it's good to have a lot of pixels, and it's good to have a lot of small pixels, what we call a matrix, right? Where we're looking at many smaller sized pixels that can give us a good representation of the object we're imaging. So again, there's the difference between spatial resolution that we determine by the camera and by the uniformity and by the collimators, etc. And then there's image resolution, which is determined by your screen, like the one I'm using right now, in terms of how many pixels in a certain screen size. Okay. So remember that all filters remove information. If we take out high frequency, we're going to lose information. So we have to find an optimal filter, and the optimal filter is going to be determined by the amount of noise that we can or cannot keep, and the amount of resolution that we want. And remember that over filtering, if you just keep low filters or low frequencies, you'll really destroy a lot of information. So here, let's look at frequency cutoffs. This is on a typical nuclear study. This is an unfiltered back projection. This is now adding a little bit of filtering where we're taking some of the high frequencies out, keeping the low frequencies. Here we're kind of a balance between high and low frequencies. And here, we've basically taken out all the high frequencies and just have low frequencies left. And you can see that the image gets much blurred as you go from the untouched image to that which we're only keeping the low frequencies. And you might imagine that if you only kept the low frequencies, you would actually blur out a perfusion defect and wouldn't be able to see it, okay? So that's why when you think about your frequency cutoffs, and there are standard ones, that it be a certain that we have enough filtering to make a nice looking image, but we don't have too much filtering where we can't see perfusion abnormalities on the images we obtain. The other issue is noise. Noise is not our friend, and the amount of noise is based on the amount of counts you attain in an image. And so, for instance, if you have 100 counts per pixel, the noise is determined by the square root of the 100, so you would have 10% noise. But if you have 10,000 counts per pixel, now you get the square root of 10,000 and you only have 1% noise. So you can markedly improve your image quality, okay, by increasing the time you image patients, increasing the counts. And the way you increase counts are two ways: either get more millicuries of radiotracer or increase the time that you're imaging someone. But that's the way you avoid noisy images and improve your image quality. Okay, so higher kV photons, you get higher count rates for any given time or dose. You have less tissue absorption, so you get better photoelectric effect, and you have less Compton scattering. And so that's why we like the radiotracers such as technetium, which are the highest ones we have really in myocardial perfusion imaging at this time using SPECT imaging. All right, we're also now going to talk a little bit about, in the last few minutes, about once you have the image, how do you assess the quality of the image, okay? So we want to look at the raw data when we do this, okay? We want to see if there's breast attenuation, whether there's diaphragmatic attenuation, whether there's vertical or horizontal motion, whether there's been infiltration of the radiotracer, whether there's gut getting involved or getting in the way of the images, whether there's abnormal uptake in other organs that are causing problems with image viewing the image, etc. And we want to look at attenuation patterns, right? So this is an example of a patient with motion artifacts. And what you will see here with motion is there's a perfusion defect here. And when you correct for the motion, it goes away. There's no longer a perfusion defect. And remember that artifacts, whether they be motion artifacts or whatever, may create abnormalities, but they may also hide abnormalities. And therefore, they're going to decrease your sensitivity, specificity, and diagnostic accuracy for detecting coronary disease if you have artifacts such as motion. Here's a patient with motion, for instance, who had x-axis motion. Okay, this is in the x-axis, not in the up and down, but in the side-to-side motion of the patient. And you can see there's a septal defect here. which if you recall this, if you were to call this abnormal, you would be dead wrong, because when we re-image this patient, he stayed still on the second set of images and it's completely gone, okay? So you really need to be cognizant of different motion artifacts, because you'll be calling things that aren't there and your specificity will go way down in terms of as well as your diagnostic accuracy. Okay. Other types of attenuation, breast attenuation. This most likely creates an anterior and anterolateral perfusion defect. It can be present on male patients as well. Don't be deceived. There's a lot of men that have a lot of upper chest fat and upper chest muscle that can cause attenuation artifacts. It's best that the breast be uniformly positioned when you're doing your stress and rest imaging. Otherwise, you're going to get not comparable images, and that's going to also affect your interpretation. This is an example of a case of variable breast attenuation artifact. Here you see an anterior defect on the first set of images during stress. On the rest images, there's no artifact. It looks normal. So you would say, my goodness, the patient has anterior ischemia. But look over here on the raw data. You can see here the breast is only partially covering the heart, causing this anterior defect. But on the rest images, the breast is covering the entire heart. Okay, so in SPECT imaging, it's all relative perfusion or relative count in terms of the imaging. And you can see that you actually would have called false ischemia here because of differential breast positioning. This is a case that we had a couple of years ago where the patient actually was an ER patient, came in, had an anterior defect, got better with breast imaging. Again, differences in breast positioning. This is called ischemic. But because we recognize the differences in breast positioning, we got a CT. And the CT, actually the CTA was totally normal coronary arteries. So again, it's important to be cognizant of this. Diaphragmatic attenuation, more common in male subjects, more common in obese subjects, most often occurs in the inferior posterior walls. Here's an example of diaphragmatic attenuation, which can be very difficult and contentious in terms of being able to resolve. There are ways we can do this with SPECT imaging. We can do, for instance, prone imaging. So this is a supine image, and you can see the inferior defect. You put the patient on their belly and you re-image them, and the defect goes away. Okay, so this is a good way. And you can see the differences in these images here: diaphragmatic attenuation, no diaphragmatic attenuation. And this just shows this patient did have significant diaphragmatic attenuation on the supine images. The patient also had normal wall motion, which would, based on these images, you would say this is a normal study. And remember that, you know, nowadays, some of the gamma cameras also can do CT attenuation correction, which is an additional option on these newer cameras. But, you know, here we do, as you know, both prone imaging as well as CT correction, depending on which camera the patient tends to be imaged on. The other issue is adjacent gut. This can be from the liver, from the stomach, or from bowel. The importance of knowing about subdiaphragmatic or adjacent hot activity is that it contributes scattered counts to myocardial walls so that it can obscure defects. And it can also create RAM filter artifacts, which can cause defects. So here's an example of someone with an inferior defect, or where you can't really, you actually couldn't tell whether it's an inferior defect or not, because there's so much gut over the inferior wall that there's no way to interpret this. Okay. And so you would have to hopefully get a second set of pictures after giving the patient, you know, milk or some kind of fluids to drink to try to get rid of the gut technetium activity, and get a better series of pictures. Okay, RAM filter artifacts. You know, we use the RAM filter quite frequently on our filtered back projections. And the RAM filter was initially designed so as to improve image quality by eliminating some of the activity or noise around the point source itself. But unfortunately, when gut gets in the way, you can actually cause attenuation artifacts from a RAM filter by eliminating these counts with adjacent activity. And this can cause false positive defects. Now, there are ways to get around this. You can re-image patients and get away and get rid of gut, etc., or you can use iterative reconstruction instead of using the ramp filter, and that can also therefore eliminate these kind of artifacts. So I'm just about 1 o'clock, and I'm just about done. But I hope you have a much better idea of, in terms of the radiotracers we use, what affects radiotracers or photons from getting out of the body, such as scattering and Compton scattering, how we try to eliminate those problems by using collimators to only accept good photons that are coming directly parallel from the patient to the sodium iodide crystal, and how even when photons get to the crystal and undergo scintillation, that we can still use other corrections using our pulse height analyzers to only take those photons which are the right energy, which therefore would be the right photons that came directly off the patient, and how we can then take those raw data, process them, and use different filtering to get an adequate picture. And once we have that adequate picture, to assess it further in terms of what types of artifacts are present and how we can manipulate the images or maybe re-image the patient to get better results. And so that's it for today in terms of the basics. I know there are a lot of basics we went over, and there's a lot more yet to go over in future lectures, including stressors, isotopes, and the many clinical applications of myocardial perfusion imaging. Thank you very much.